Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we are going to be talking about a very interesting topic. It is understanding your genetics. I have Karen Narum here with me today. She is a women's health nurse practitioner. She is with TMCOne at the High Risk Breast Clinic, and she began her nursing career in 1990. Initially, she worked with as a medical and surgical nurse and discovered her passion for women's health shortly after transitioning to labor and delivery. In 1995, she became a women's health nurse practitioner, one of the youngest nurse practitioners in the state at that time, and began working in OB/GYN specialty practices and breast health clinics. She was with her mother through a cancer diagnosis and understands how many factors contribute to a patient's overall quality of life. With this in mind, Karen helps patients build a care plan that will benefit them medically, socially, and emotionally. I want to welcome you here today, Karen.
Thank you.
So this is Karen's first time with us, and I'm excited because it's a topic that we've not been able to dive into before. We do have an online audience along with an in-person audience. So if you have any questions for Karen during her presentation, please leave them in the chat and I'll answer those and we'll get those answered afterwards. I'm going to go ahead, Karen, and turn it over to you, and you should be good to go.
Okay, good afternoon. I want to start off with I am not an expert. In my high-risk clinic, I have a conversation quite frequently with women about genetics. And so my goal today is just to I can give you the top layer, just to brush about, what is going on in this up-and-coming world of ours. And hopefully you leave here with a better understanding of the purpose and use for genetic testing. So genetic testing is a growing science. We all know this, right? So there's lots of different ways to use these genes. Sometimes they use the proteins to look at some things. They look at the chromosomes. And so today I want to be focusing on cancer risk, but diagnostic testing. So folks who maybe we suspect they have something, or before you have children, you want to find out because this has been prevalent in your family. So we have diagnostic testing for things like cystic fibrosis. Prenatal testing, they use genetics to find out if there's a chromosome abnormality. Newborn screenings is helpful if there's a family history of sickle cell anemia. These are just a few examples of the things that are used. Pharmacogenetics is kind of a new up-and-coming thing. I don't know how readily available it is, but this is where, say someone's been on a lot of medications for depression and it's not working, they can do some genetic studies to see if maybe there's a different form of a medication, a different mixture that may help them through that a little easier. Then we have ancestry, and some people say this is for fun. Ancestry, I have a lot of my adopted patients who choose to go this route. They want to know a little bit more. Am I really French and Irish or not? I've had a few patients, I have some good and bad stories, where they have come across some biological family members who either knew or didn't know about them, but it gives them an opportunity to try to find out some biological medical history for themselves. I put 23andMe up there because they also talk about doing BRCA1 and 2 testing, and we'll get into that a little bit later, but I do want to kind of put that on our radar. And then predictive testing is what we're going to talk about today. Cancer risk, right? On a side note, I have a lot of patients coming in saying, my mom had breast cancer. They told us it was not genetically inclined and she didn't need chemotherapy. So what we're finding is people are getting things a little confused. This is genetic testing on the tissue or the cancer per se. In breast, there's a test that we can do that will help us figure out a reoccurrence rate. And this has been huge in helping filter through who would benefit from chemotherapy and who really doesn't need it. But folks get confused because they just throw it into this genetic pile. So they have this false sense of security that mom's genetic testing was negative, when in fact, maybe she wasn't tested. Okay, so genes have lots of functions. If one of them is not working up to par, it can affect others. The example I give my patients is I think of our genes as this military, this circle around us. And if one of our soldiers is feeling ill that day, isn't feeling so great, then something might be able to pass through him a little easier, but it's also affecting the soldiers around them. So I kind of think of our genetic pool, if you will, as a little bit of our protection. So when there's a mutation, that soldier, that gene, isn't functioning in the manner in which we think it should be or we're expecting it to. It doesn't mean there's going to be a breach in our security, but there's a potential risk for that. So genetic counseling, folks get confused between counseling and testing. So genetic counseling is an interview, basically, with a genetic counselor. These folks are certified in genetics. This is different than a geneticist. A geneticist is a medical doctor who can give more recommendations based on, I think you should have surgery and you shouldn't. Whereas a genetic counselor is going to give us information on this gene mutation increases risk for this. What do you want to do about it? Here are the guidelines. They can't tell patients have surgery, it's going to be better. That goes to a physician level. So some genetic counselors, I think, have patients referred in and the patient thinks that the counselor needs to tell them if they should have surgery or not. Genetic counselors can specialize in certain areas. So our obstetrics here, they have counselors that specialize in the prenatal, carrier, those kind of areas. I have a young man that was sent to me suspicious that he may have something called Marfan syndrome. So I'm getting him up to Mayo Clinic, and there is one of their genetic counselors that's her thing. So he's got a little bit of a wait, but we're trying to get him into the person who has the most knowledge about that. When you have a genetic counseling appointment, it's a deep dive into your personal and family history. So the more information you have when you sit down with these folks, the more productive the appointment's going to be. So they want to know, have you had any cancer? First degree family members? If so, what age, what type, what do we know about it? Ancestry is important with this because there are certain groups of folks that have a higher risk of carrying a gene mutation. And we'll talk about BRCA1 and 2 just because it's got more face time than anybody else. But folks of Ashkenazi ancestry are more likely to have a mutation in the BRCA1 or 2 gene. So these are things that genetic counselors need to know in order to help best guide us on who's appropriate. Genetic testing is not appropriate for everyone. And so the counselor will help make sure that we have an appropriate candidate that meets criteria. And if they meet criteria, do they really want to have the testing done? We need to have a talk about pros and cons. When we talk about criteria, that's a little waffly because insurance companies have their own and other people have their own. And so we kind of come together to try to say this is an appropriate candidate. The most appropriate candidate for testing is the person who had cancer. If my mom had cancer, she's where we get the most information from. If she has a mutation associated with her cancer, bingo, I'm at risk. If she didn't, then she didn't pass anything on to me in a genetic format that may increase my risk. And we'll get into that a little bit more too. The genetic counselors, if they deem that someone's appropriate, they're going to help ensure that the correct genes based on their personal and family history are included in the testing. So yes, we have big panel studies, but for instance, the young man with Marfan's, I want to make sure that those panel studies include the genes that we would be suspicious for. So doing a big panel often covers a lot of things, but the counselors are going to make sure that we are doing this for the right reasons and including the appropriate information. Pros and cons to testing. Some people have a hard time with this, but there's pros and cons. GINA laws went into effect probably 17, 20 years ago. As I'm getting older, the time's getting away. Basically, the GINA laws say that medical insurance companies cannot discriminate, that they can't use a gene mutation as a pre-existing condition and say, oh, no, we will not take care of you because of this. You probably all remember a time where medical insurance did that. If you had cancer and you lost your insurance, the new insurance could say, that's pre-existing and we're not covering it. So these GINA laws have covered that for us. Hopefully they're not erased or anything like that, but they've been there for a while. There are scenarios where you will be asked to disclose if you have a genetic mutation. I blame this one on my husband because he's older than me. But every couple of years, my insurance lady comes a knocking, my life insurance lady. She wants to know, what's new in our medical history. And I know this information is being used somehow to calculate my rate, right? So I have some young folks that say, wait, I don't have life insurance. Let me get that first. But these are things to think about. Long-term care insurance apparently can also discriminate, but I don't have long-term care, but patients who do tell me once they get it, that they're usually not asked questions again. That's kind of a done deal. The military is a new avenue. The military, in some instances, will ask recruits if they have a genetic mutation. And in some instances, this may be enough for them to not be accepted into the military. So we really need to have these talks. If you have a young person who's trying to get into the military, maybe they're not anxious to get testing done. These are things people have to know so they can make the decisions for themselves. Ethics, right? What are you going to do with this information? One time I had a young girl come in. She should not have been tested. She was 18 years old. There was no reason, and nobody explained the results to her. So we just scared her. By the time I saw her, she was a couple of years older and thought she had a death sentence. So we have to make sure people understand what we're doing and not willy-nilly make knee-jerk decisions. So there's got to be some ethics about this. Ultimately, I tell my patients, what is this information going to mean to you? You're the only person that I'm doing this for. What is it going to mean for you? So I have some patients that say, I want to know, I want to be prepared, I want to be proactive in my care. I have other patients that say, I don't think I'd do anything different. I know my mom had breast cancer, so I'm going to get my mammograms. Some folks will say, I have children. I want to do this so I can share that information with my children. I have one patient who stands out in my mind, and she taught me that everyone looks at this differently. She's one of 5 siblings. 2 of her siblings have a gene mutation and 2 don't. She doesn't want testing. She's got a 50% chance of having the gene or not. And I cannot convince her that if you don't have it, we move on, put it behind you. And if you do, then we make a very definitive decision about how you want to take care of it. So she taught me that everybody looks at this differently. Now, pre and post counseling testing. So the genetic counselors are available to us before you make a decision about testing, but they're also available to us after testing is performed. So that way, if there's a mutation, they can give us their expert opinion, whatever guidelines are out there, to help guide us on what would be an appropriate plan of care after that. I also think that usually they give a nice handout, things you can share with the family, educational stuff. So one of the things I wanted to point out is we have a new grant program, and I have some of these flyers up at the table. So genetic counseling, there's not enough genetic counselors to go around. And we have a grant program from the TMC Foundation, and we are partnered with Mayo Clinic. So we get to utilize the genetic counselors at Mayo Clinic through this grant program. I'm the keeper of the funds, if you will. So folks are referred to me. I make sure they understand in order to make it the next step over. A lot of insurance companies are getting on board with testing, but some want you to have counseling before you can have testing, and they don't pay for the counseling. So this kind of bypasses some of that process. But if you know somebody and the criteria, there's just kind of a general guideline. I look at people as individuals. So these are general guidelines, but if somebody's worried about it, I'm happy to see them and go over it and go over their personal stuff to see if it's worth taking the next step. What did I do? Hold on. There we go. Genetic testing. It gave me the button, guys. Sorry. First thing with genetic testing, not all labs are, I want to say created equal, but they're not all the same. I really prefer a lab that specializes in genetics. They're not doing CBCs. They're not doing other things. They're just looking at genetics for us. These specific labs usually have more resources available to us and our patients. I also want a lab that does full sequencing, that's looking at from front to end of these genes, spelling them all the way out. So that 23andMe that we talked about earlier, they're doing portions of the gene where someone of Ashkenazi ancestry may be more likely to have had a mutation. So some folks come in with this false sense of security because they said, look, my BRCA1 and 2 are negative, without realizing that it wasn't a full sequencing of the gene. The genetic labs that I utilize have patient assistance programs. They really work hard to help folks get it if they're appropriate. The days of having those surprise bills of $3,000, we don't see that anymore. So that's made it a lot easier for us to order as well. They also typically have genetic counselors on staff. So if there's a complex situation, you can call. That's where all of our genetic counselors are going. They're going to these genetic labs because they're able to get in deep with the science and the research. Our genetic testing labs also offer panel studies or single genes. So if I know my mom had a BRCA mutation, I don't have risk for anything else, I can order just the BRCA. I don't have to do a panel. And again, as I said, they do a full sequencing from front to back. They spell the whole gene. I think I messed up, Jennifer. Oh, it's up there. Nope, I went too far. I'm so sorry.
There's a slight
Okay.
delay on what's on the screen too.
Pushing buttons. All right, so genetic testing results. When we do results, there's actually 3 potential results: a yes, a no, and a probably not. So is that as clear as mud, right? So negative in this case means that all genes that were included were spelled appropriately. They were sequenced out. This equates to no increased risk based on a genetic mutation. Positive in this case means, yes, we found a mutation. Mutations that come back as positive mean we have proof and data. This misspelling is a mutation that can increase risk. Depending on which gene it's on and what the misspelling is, then that can give us an idea of what risk we have. I put another handout out that kind of looks like this, and this gives us an idea. These are the genes that are tested, and these are the cancers associated with the mutation. So if you look at just breast cancer on this, you're going to find there's a lot more than just BRCA1 and 2 involved. Yeah. Variant of unknown significance. This is a misspelling, so it's not a normal negative, what we'd expect to find. It's a misspelling somewhere along that sequencing, but this misspelling is not a known mutation. These will need to sit in a pot until we have enough data to wholeheartedly call them yes or no. These variants are typically reclassified to be negative. So that's the yes, no, and probably not to this. Very confusing for patients. So I'm going to break it down just a little bit more. So negative genetic testing results. You're like, whew, right? This means there's no increased risk for cancer based on the genes that were looked at. This does not guarantee that you will never have a cancer diagnosis. This does not conclude. So if my testing's negative and my mom had stomach cancer, it does not mean that my mom's genetics would have been negative. It just means I don't have them. So again, the person who's had cancer, we get more information from. When we were talking about, I had a patient come in the other day who has metastatic disease and said she didn't want genetic testing because she was afraid it would influence her life insurance. And I'm afraid whoever talked to her about it didn't quite explain that your diagnosis of metastatic disease is probably influencing your life insurance more than a genetic mutation. So she's still the most appropriate person for testing. That's going to give me a whole lot more information when I am trying to plan risk reduction stuff for her daughter. And most importantly, negative genetic testing does not exclude you from your mammograms, your colonoscopies. So this doesn't mean, I don't have to do any of that. It just means in the genes tested, we don't see an increased risk. Make sense? Positive. So positive is not always a good thing, right? So this means there was a mutation, a known misspelling. This mutation is known. When we see this, we can say, here's the incidence of cancer related to that particular misspelling. This is not a guarantee that you will ever get cancer. This just means you're at higher risk. So BRCA mutations hold about an 80% risk for breast cancer. A CHEK2 mutation holds about 30%. So it really, it differs. I have a friend who found out she had a BRCA mutation at the age of 65. She went to see the geneticist, which we don't have in Tucson anymore, by the way. But the geneticist basically told her there wasn't a huge benefit for her, and she had a lot of other medical issues, to have a mastectomy at that time in her life. Her 40-year-old daughter, it was a different story. Her daughter had more years where this could potentially happen. Not that my friend had outlived her risk, it's just as she got older, the benefit of a mastectomy wasn't quite the same as it was before. So again, we have to look at people as individuals. Depending on the finding, then that helps us kind of figure out a plan of care. What do you want to do about this? First degree family members. So first degree family is your parents and your siblings would all have a 50% chance of having the same mutation. They also have a 50% chance of not having the same mutation. So this is where I instruct patients that they need to share their results with their family, and that their family should consider having this discussion for themselves. I wanted to bring up that there are some mutations that they consider to be autosomal recessive. This means you have one strand that's got the mutation, but the other strand doesn't. This strand's taken over. We don't have to worry about this one. This MUYTH, about 1 out of 100 people are going to have a single strand with a mutation. If you have the double strand, then you have an increased risk for colon polyps. But the single strand, the risk isn't quite the same. This is very common. And again, this is where the testing labs make a difference. They give us guidance on, was this a single strand, a double strand, what do we do from here? And then again, this is where it's very, I think, beneficial to the patient to have that post-genetic counseling, so they can kind of fine tune and deep dive into the particular mutation you have so that you can understand it better. The other thing that the genetic counselors do that's lovely is they give us a nice printout of their recommendations. I give this to patients. You move to California, take this with you so that your new doctor and providers know that you've already got this, and here's a plan of care. Variant of unknown significance. So this is where there's a different spelling. I always use the word there, but you could use the word too. If somebody misspelled the word in the context of the sentence, unless you're an English teacher, you give them a pass. You know what they meant. It doesn't really change what they're trying to tell you. I also found this picture. We all know of people who have 2 different colored eyes. It's a variant from what most of us have, but their eyes still work. A variant of unknown significance. So these are negative until proven otherwise. Another reason I like the big labs is they have a whole team of researchers that monitor this. They do nothing else but monitor this. They share the data with other big labs. And once this is reclassified, once they have enough information to say, we're more comfortable that this is not going to be a problem, then they will contact the ordering provider with a reclassification statement. Now, sometimes this can be a year or 2, it might be 20 years. The other reason I'm picky about my labs is if somebody moves and they have a variant of unknown significance and I get a reclassification letter, I'm not going to know where to find them. So I tell my folks who have these VUSs, if you and I lose contact, you can call the lab every couple years and ask them, is there an update on this? Because most of the labs will talk to patients about it. It's uncommon that we'll see these VUSs be reclassified to positive, at least in the genes that they're looking at right now. I feel like they've got a pretty good handle on that. Okay, so this is what gets everybody. Even with a strong family history of cancer, we only find gene mutations about 5 to 10% of the time. Yeah, most people think it's a lot higher than that. It's incredibly significant for the folks we find the genetic mutations in, but it is not the end-all answer to what's causing cancer. It's a piece of our puzzle. Most cancers that we see in families are probably related to other things that you share. Your environment, people who grew up on the south side here in Tucson probably had some exposure to some contamination. I hear this from people who grew up in rural areas or near rivers where there's known contamination. What was your diet, your lifestyle choices? Those things also, we may see more common trends in families, and those might be contributing to the cancers that we're seeing. The bottom line is that most cancers are sporadic oops that happen, okay? Most of them, about 80%, are gonna be an oops. Yeah. So what can we do to prevent cancer? I'm coming off of a summer, I got to do this online conference with Mayo Clinic. It was 6 sessions, really good data saying lifestyle, healthy lifestyle choices can probably decrease at least breast cancer risk by 30%. That's huge, right? The two things that stood out: quit smoking and exercise. So people who smoke and don't exercise were getting cancer at a higher incidence than non-smokers. Again, this isn't going to, bad lifestyle choices. We can't tell our cancer patients that's what happens, but we know that these are things we can do to be proactive in our care. Exercise, 30 minutes a day, 5 days a week, right? In the conference I was in, we all had this conversation. I struggle with this. I work, I'm in the car too long. Even if we get it in little bursts, just always walk like you're running late. Park a little further back if it's safe. Take the stairs. My husband laughs, but I volunteer to do the vacuuming because I feel like I'm getting my exercise in. So even getting it in little bursts, as long as we're staying active, you get credit for it. Diet, they really push the Mediterranean diet, and I always laugh at that because to me it's the common sense diet. Fresh fruits, vegetables, low-fat meats. If you're one of my patients, you've heard me say this before. Go to a birthday party, have a piece of cake. Don't eat the whole cake, and don't go every day, right? So nothing in excess. Alcohol, 16 ounces a week or less. Now, some of my wine drinkers get really upset with me. Apparently that's not much wine. But this is a goal to look at. We all know that smoking is on that carcinogenic list, but guess what? Alcohol is too. And I think that's one that's been easily pushed under the rug. Participate in your screenings. Screenings don't necessarily prevent cancer, but they prevent death from cancer. If we can catch things early, the treatment, even if it's a bad, ugly cancer, if it's caught early, the outcomes are so much better. I laugh at this picture because I'm saying exercise. I don't want you walking down the middle of the road. And I hope that was morning fog and not smoke that they're walking into. I figured that out later. And because I am in the high-risk breast clinic, I have a little soapbox. This is Breast Cancer Awareness Month. Please get your mammograms, please. Again, they don't prevent cancer. They help us prevent death from cancer. I do not believe there is any age where we can say don't get it. Our risk goes up as we get older. My grandma used to say her risk for everything but pregnancy went up, and she was right. Treatment will be circled around the individual. Not everybody's going to need the same thing. So please keep getting your mammograms. It's going to help us keep you ladies vibrant. All right, thank you.
Thank you.
So thank you, Karen. I have a couple of questions I just wanted to ask. Can you tell us a little more about the genetic counseling program? How does somebody get into that it's your Mayo collaboration, and what does that look like? What would that process be?
So on the flyer, they need to just get a referral to me. If they can just ask their provider to send a referral to me. Usually I approach the appointment as my normal high-risk screening just to see what's going on. I have males that come through, of course. I'm going to do things a little differently, but just a referral over, they could put, I think it says on the flyer, like Mayo Genetics is what we're interested in. And again, because I'm the keeper of the funds, we'll have folks that come in that say, well, I just want to do it. And I need to make sure that what I'm handing over to Mayo is appropriate.
Okay. And so when you meet with somebody, or if you do the counseling, I guess, right? And then is it afterwards then that you find out whether it's appropriate for it to go to Mayo at that point for the,
Yeah.
Okay. So then they would have the blood work done at that point?
So the way this works, and I'll do it even for my patients who don't come in looking at Mayo, it's one of my tools. So I have the conversation, if somebody comes in and shows me their mom's paperwork that shows they have this gene mutation, maybe we don't have to go through Mayo, but we still can. So the counseling part is an option. But I like to make sure that we're sending the right people to Mayo Clinic. So that's my first screen. Through Mayo Clinic, the conversation will help them decide if they're an appropriate candidate, and then help the patient decide. They do not have to decide at that moment if they want testing or not. Some will come back to me later and say, yes, I want to do it. I can look at the results and I can order the testing there. So we have a lot of different ways of doing this. I've had patients come in who have a known mutation, and I get them to Mayo so that they can get a better understanding.
Okay. And how long is the process normally if after somebody sees you, how long does it take for all of the testing to be completed? I know it takes some time, so.
It does. When I do testing on my own, so new cancer patients, this is part of our conversation. So when I just go straight and do my little spiel that I've done with you all today, and the patient's pretty sure she wants this done because it's going to make a difference in her treatment options, usually we can get them back in about 2 weeks when there's treatment decisions being made. If there's not, it's usually about a 3 to 4 week turnaround. So if we throw in the Mayo Clinic piece, we're looking at probably another week to 10 days, depending on how quickly they're able to set up the appointment.
Okay, so I do have the number running on the screen as well for anyone who might be interested in order to contact you. So they do need a referral. So I guess I just want to make sure everyone understands that. And the number is 520-324-2778. And so that would be how they can get in touch with your location. And can you tell everyone where you work out of, Karen, as far as the TMCOne office?
So I am part of TMCOne. I'm a specialist, but I'm inside the primary care clinic on Wyatt. So we're on the hospital campus, but we are not in the hospital. And we have our own parking garage and valet parking out front. It's a 2-story building on the corner of Wyatt and Grant.
Great. Okay. Thank you so much for being here today and sharing all of this great information. I hope people will come out. I know it is Breast Cancer Month, and it was great that you're doing that. We actually are also supporting Pink Out in the Park this year, which is coming up in October with the Cancer Society. So thank you again for being here, and we will see everyone later. I've got our next talk is set for next week. It will be on Wednesday, October 12th. Again, our topic is for the health of it. So next week, we'll be talking about making the smart carb choice. I look forward to seeing everyone then. It'll be on Wednesday, October 12th at 10 a.m. Thank you.